Great. So, hi everyone. Welcome to the Statistical Methods for Health Equity webinar series. This is a monthly webinar series focusing on statistical and machine learning methods that have the potential to promote health equity. So, for example, methods that can shed light on the complex factors underlying inequalities or fairer algorithms that appropriately take into account the biases that exist in biomedical datasets. The series is co-hosted by the Alan Turing Institute, specifically the Health Equity Interest Group, the UCL Statistical Science Department, where I'm based, and Data Science for Health Equity. Data Science for Health Equity is a global community of experts and enthusiasts working at the intersection of data science and health inequalities. And our aim is to ensure that the latest research and innovations in data science, machine learning, and AI improve everyone's health, and especially those in underserved populations. If this sounds like something you're interested in, then there are a few ways to get involved, which I will post in the chat very shortly. And today it's my great pleasure to welcome Dr. Karandeep Singh. Karandeep is an assistant professor of learning, health sciences, internal medicine, urology, and information at the University of Michigan. And he directs the Machine Learning for Learning Health Systems Lab, which focuses on translational issues related to the implementation of machine learning models within health systems. And this is in fact what Karandeep will be talking to us about today. So without further ado, I'll invite Karandeep to share his slides. We'll have plenty of time for discussion towards the end. So do, pop questions in the chat, and we'll have time to get to those towards the end of this hour. So thank you very much, and over to you, Karandeep.
Thank you. Thank you for having me. And I think it's only fitting when we talk about health equity that we first talk about ways that things fail before we try to think about, ways to kind of correct those failures or think about those. And unfortunately or unfortunately, I've had a lot of experience with seeing different ways that things can kind of go wrong when we try to take machine learning models, even regression models, and try to implement them to make and support clinical decisions in clinical care. So I'll talk about some of the ways that AI implementations can fail. This is not an all-exhaustive list. And then we'll kind of end with on a positive note and talk through what are some of the things we can do to try to build and deploy better models. And I'll try to leave time at the end for kind of questions and discussion. I'd love discussion, and definitely, feel free to share your own experiences or push back on any points that I make. I'm looking forward to some good discussion. So when I talk about AI implementation, I know most folks in the room here will know what I mean by that. But just to be a little bit more specific, what I'm really referring to is an AI model that produces a recommendation that gets reviewed by a person and that is then implemented into a clinical workflow. This is often referred to as kind of the human-in-the-loop model of AI or augmented intelligence, where you're not automating away clinical workflows, but you are kind of incorporating a clinical expert or a person who has the requisite skill set into that decision-making process. But if this is, of course, an oversimplification, and there's lots of ways in which this is an oversimplification. One of the ways is that many times the models that we work with don't actually produce recommendations. They often produce a risk estimate, and then by us applying some level of a threshold to it, we turn that risk estimate into a recommendation. But this is not the only way that we implement AI. There's probably dozens of ways. I'll show you one variation on this, which is that sometimes we have an AI model that produces a recommendation, and that recommendation actually gets implemented into a clinical workflow to then reorganize or streamline a person's work. So an example of this I'll give is we have an algorithm at University of Michigan that we use in the hospital, in hospitalized patients, that ranks patients on how sick they are in terms of how likely they are to need intensive care unit level care. We then have a rapid response team that sits in the hospital. It's a series of intensive care unit nurses who kind of respond to any event where someone's having a code or someone looks like they're getting a little bit sicker and might need to go to the ICU or require a closer evaluation. But who are they going to go check in on? Well, they'll check in on the patients where there is an actual event being called. But if there's no event actively happening in the hospital, they actually have a list of patients that is the sickest patients sorted by a model, who are currently not in the intensive care unit. And so rather than just kind of sitting around, they'll look at the next sickest patient and go check in on them and talk to their nurse and see if there's anything that they can do to try to prevent or streamline the transfer to the ICU. So in this example, there's still a human in the loop, but the model is first streamlining which patients they're being given kind of they have on their list who they can then prioritize using their own judgment. So because there's so many different ways that AI can be implemented into a clinical workflow, there's really no such thing as kind of an ideal implementation, that's kind of cuts across all of those different use cases. But I think there are still some general things we can say before we talk about how things fail. So when I think an ideal AI implementation is one that produces recommendations that are informative and that you can act upon, ones that allocate clinician and staff time more effectively, and then ones that allocate resources towards people in our communities who need them and may benefit from them. And those aren't always the same people. So if we think about, things like situations where we have kind of our highest risk patients. Well, the highest risk patients may be the people who need the resources or deserve the resources in the sense that they're often the ones who are the sickest. But in many cases, that risk may not be modifiable. And so if we direct all of our resources to those people, they may not necessarily be the ones that benefit from the resources. So there's this kind of tension in terms of health equity around, do you allocate resources based purely on risk, or do you allocate resources based on kind of expected benefit? And in some cases, you can try to estimate that benefit, but often you can't, which is why we use risk as a proxy. So when I think about why AI implementations fail, I often think about issues that are related to the AI models and the recommendations they produce. And that, of course, takes into context the context in which those models are being used. But then the second issue is issues related to the interventions themselves. So an AI model has never saved someone's life. The way that an AI model could help someone is if you link it to some kind of intervention as part of a workflow. But then the reason that those things can fail on the intervention side is that the way that they reorganize work, or that the way that they reallocate care, tends to be inequitable, unfair, or problematic in that it produces too much work. And so even if you have a good model, you link it to an ineffective intervention, you get a failed implementation. So I'll spend most of this talk actually walking through both of these sets of issues with some examples and stories. So first, we'll talk about why AI models fail, just the models themselves. So these are not all inclusive, but I think these are some key reasons why AI models fail. And we'll walk through each of these. So lack of transparency, lack of reproducibility, lack of transportability, issues around net benefit, and I'll explain what that is. And then issues around predicting non-modifiable risk, where we actually are maybe not identifying the right set of patients. So transparency is a big issue. And I would say, I know it's an issue everywhere because there are, like fracture risk scores that are proprietary that came out of the UK that are, I think have issues with them that have been widely published about. In the US, I think the transparency issues largely come from the fact that we have a very monolithic set of electronic health records, and a lot of the models that are actually being used in clinical care in the US when it comes to kind of key time-sensitive health-related issues like sepsis, like inpatient deterioration, which is the risk of going to the ICU, those things are often coming from electronic health record vendors. And because they're coming from vendors or companies, many of these models are not actually to be found in the peer-reviewed literature. They're kind of only available to customers. And even the information about those models is often marked as kind of proprietary and confidential. So you'll rarely see information about these models kind of not just being published about, but even just being shared even on social media or in blog posts or online. So this is a set of, I think, 5 different models where the information sheet was made available to customers of that electronic health record vendor. And some of my colleagues at Stanford, led by Nigam Shah, took 5 of these models, looked at the actual information sheets they were given, and said, based on public, kind of a reporting guidelines that tell you what the best practices are for what to report, how complete are these model briefs or information sheets? And if you look at the tripod guidelines, which are kind of a widely accepted set of guidelines for reporting prediction models, when you look at these 5 models, about half of the items, about 50% of the items that you expect to see reported in that model brief is actually there. So even ignoring the fact that these information sheets aren't available to the broader public, even to the customers, not all the information that you would hope to see or expect to see in kind of an information sheet is there. And some of that situation has changed since this publication came out, but I think this is still not this is still a reasonable assessment of what a lot of these vendor-driven model briefs look like, even across other vendors. So that's kind of transparency as an issue. And I'll talk about why I think that's a real issue and it can impact a lot of different things. Look, an example of where I think this really did matter was that there is a model developed by an electronic health record vendor that was predicting whether a patient would show up to their outpatient appointment. And the idea here was, this is a no-show model. And if a person is not going to show up, that we would then potentially double book that patient to prevent there being kind of an empty clinic slot, or that we would call that patient, try to find out what is their risk of not showing up, and is that risk something that we can modify? Well, it turns out we were looking at trying to implement one of these models, and as were our colleagues at UCSF in San Francisco. And what we found was that the main model that at that time was available to implement through the electronic health record vendor had religion as a predictor. So we kind of looked at that and were really puzzled. There was no explanation for why religion was included. I mean, you could certainly think about reasons why there are days of the week where certain folks of certain ethnic backgrounds or religions might not be wanting to have doctor's appointments. But that's also a question you could just directly ask people. You wouldn't have to make any assumptions based on their religion. And so this was not a model that was, in the literature that no one was using. This was a model that at least, 50, 60 organizations were already using. And so I think the main issue with transparency is that when there is an issue like this, where it's not publicly available, sometimes it takes a lot of time by the time that these models have already been fairly widely adopted before someone really reads the fine print and notices that there's a problem. And that problem would probably have been noticed a lot sooner had it been kind of available in the public sphere and publicly transparent. So what ended up happening with this model is they ended up taking religion out of the model in a subsequent update. And that update is probably the version that most people are using now, if they are using such a model. But I think this is an example of where the lack of transparency ultimately led to decisions being made based on people's religion in a way that I think if you ask most people, they would view as unacceptable. Another related issue, but not directly related to transparency, is the issue of reproducibility and lack of reproducibility. You could also argue this is not just reproducibility from a paper standpoint, because many of the times the papers that are published might describe, how a model is built very well, but you could think of this as lack of computational reproducibility. So here's a model that was published by the DeepMind group out of Google. It was a model that predicts acute kidney injury, and this was published in Nature, a very widely known, well-respected journal. They published a model where they predicted the risk of acute kidney injury using a set of 700,000 US veterans. And, at the end of this, they were able to achieve what they characterized as state-of-the-art performance, kind of the highest area of the curve that had been reported in this space by at least 10% or 10 percentage points. So here's what they said in their kind of conclusion at the end of this work being published. They said, despite the state-of-the-art retrospective performance of our model compared to existing literature, future work should now prospectively evaluate and independently validate the proposed model to establish its clinical utility and effect on patient outcomes, as well as explore the role of the model in researching strategies for delivering preventative care for AKI. The reason this model was a big deal was that it was predicting acute kidney injury 48 hours in advance. And the thought was that if we could predict acute kidney injury that far in advance, that maybe we could step in and actually prevent it from occurring. There's just a couple of challenges with this when it comes to reproducibility. One, the data set for this is not publicly available. Even though DeepMind was able to receive a de-identified copy of this data set from 700,000 US veterans, that is not a data set that they were allowed to share, nor is available for other researchers to look at. Problem number two is that the model is actually not published anywhere. So even though if you needed to prospectively evaluate it and independently validate this, you would essentially need to recreate this model completely from scratch using this data set that's not available to you, because neither the model nor the data set are available. And this third thing is that one of the key reasons why they felt this model did so well is all of the pre-processing work they did to prepare the time series data for prediction modeling. One thing that was not emphasized in the paper, but which I'll mention, is that while the headline of the paper was based on the performance of a recurrent neural network model, they actually published results from other modeling techniques as well, including logistic regression. And interestingly, their logistic regression that they published in this paper was also state-of-the-art compared to everything that had been previously published. So it wasn't so much just the neural network, it was actually something to do with the data preparation. And so even the data preparation code for this model was not available. So to try to reproduce this model, you would need to write your own software package that could do the data preparation in the way that they described it, obtain this data set to try to actually recreate this model, and then to train the model in a secure environment where you could then try to evaluate it and see how well it does. So you can imagine that's just a lot of work and very hard to actually try to do. So that's what we ended up doing. We, at the time this paper came out, coincidentally had a contract with the VA to do exactly what this paper described, which was to build a model to predict acute kidney injury. So we were already planning an approach that was fairly similar to what DeepMind published, but when this paper came out, we tried to make it as close as we could within the constraints that we had, which were a different set of constraints than what DeepMind was facing. So what we ended up doing was we cleaned the data in a very similar way. We were doing all this on secure VA servers. We weren't allowed to remove the data outside of the VA servers. And we tried to see not just how well the model did overall, but how well the model did across the 110 VA hospitals in the United States. So the VA hospital system is not just one hospital, it's actually 110 different hospitals. And so we wanted to see how much could we reproduce it, but also how much variation is there in model performance when we look across the different VAs. So for a variety of reasons, primarily to do with the fact that we did not include billing codes in our model, we were able to get fairly close to what DeepMind reported, but not quite there. And that's the red bracket on the left. That difference between what DeepMind reported in terms of their area of the curve and what we got is what I would refer to as kind of computational reproducibility. We were able to get close, but not quite there, but for reasons that I think are readily explainable. But what they hadn't reported, which we looked at, was this issue that at some VAs, the model is amazing in terms of its ability to discriminate those who are going to develop acute kidney injury from those who are not. And at other centers, it's terrible. And this is not purely only a function of sample size. I kind of cropped it out of this image, but we looked at sample size, both in terms of overall sample size, in terms of number of predictions, in terms of event rates, and none of those things was cleanly responsible for this variation that we saw. So just to give you a sense that, even though this model might work well overall when looking at the VA as a whole, if we're using the model at individual hospitals, there may be hospitals at which the model looks great and hospitals at which that model looks not so great. So those are issues of transportability across clinical settings. Many times these issues intertwine, and issues related to transparency and reproducibility and transportability can affect one another. One example of this, I think, is where a situation where we looked at a proprietary sepsis model that was widely used across hundreds of hospitals in the US, but because it was coming from an electronic health record vendor, there was not a single peer-reviewed paper that was published about this model, despite its really widespread adoption. So when we rolled it out and we were piloting it at our university, we noticed in our handful of units where we were piloting it in the hospital that our sepsis committee, who was working with the model, felt like the model wasn't quite as good as what the numbers would suggest. Because not only was the model overall a reasonable model, the vendor had actually looked at the model performance at our center and said, the model is doing great. Area under the curve is quite high at your center, higher than what we were getting on average across other centers. So with that discrepancy of the model seemingly acting worse or feeling worse than the numbers suggest, we decided to independently look at it. So what is the EPIC sepsis model? It's a penalized logistic regression model built from a pooled sample of 400,000 patients. And if you look at the things that go into this model, the data elements, right? They're things that are on the surface of it, very reasonable things. Things like vital signs, things like medication orders, laboratory values, comorbidities, and demographic information. And we're predicting sepsis, which is a kind of reaction to the body's reaction to developing usually a bacterial infection, although not always a bacterial infection. And so our ability to predict this is oftentimes going to be looking at, does someone have a fever? Or is their heart rate elevated? Do they have an elevated white blood cell count? And all these things combined will start to make us think this patient may have sepsis. When EPIC tested this model at 3 different centers, they noticed an area under the curve that was somewhere between 0.76 to 0.83. And at many institutions, including ours, they were saying it was actually even higher than that. So this looked all reasonable. We said, okay, this is all kind of reasonable. And so we wonder how we'll find the model to do when we look at the model against our own timestamps of sepsis. So interestingly, if you're trying to predict the onset of sepsis before it happens, which was kind of the advertised use case of this model according to the vendor, we found an error under the curve that was much lower. That was a 0.63 rather than that 0.76 to 0.83 range. But interestingly, if you're trying to predict sepsis in the 3 hours after it happens, the error under the curve is much, much, much higher. It's actually 0.80. Now, just to put this in context, there are actually good reasons to predict sepsis even after it happens, because you can still are in the time window where you can give antibiotics, you can give fluids, you can check a lactate, do some confirmatory testing, see if they're responding. So just, it's not just that we want to predict the onset of sepsis before it happens. The reason we looked at that as our kind of main outcome was because that was the purported use of the model according to the vendor's sheet in terms of how they were defining sepsis and the use case for this model. So we looked at this and said, that's interesting that there's this huge discrepancy, both in terms of what we found and what was being reported more generally, but also in this 3-hour window immediately before the onset of sepsis and up to 3 hours after the onset of sepsis, if you include those scores. This was also a reproducibility issue. So I told you our area under the curve was 0.63. The vendor's area under the curve on our data was actually 0.88. And so immediately this is, kind of a reproducibility issue right away. Now, the main reason for this reproducibility issue is that we were using different definitions of sepsis. The vendor had kind of come up with what was, in their mind, a reasonable definition of sepsis. At that time, there wasn't a standard definition when they started working on this because the sepsis 3 definition hadn't come out yet. And we were using our sepsis committee's definition of sepsis. And so when they track the quality of care we deliver at Michigan, they have specific criteria they use to define sepsis based on published definitions. And so when we were using that to decide the time zero for sepsis and who has sepsis, the area under the curve was much worse. And so at this time, when our paper came out, the vendor really said, this is a single center evaluation. They failed to reproduce our findings. So the issue is really a failure on our part and not on the vendor's part. But this is not a generalizability or a transportability issue. This is really just a single center problem with this model's performance and how it's being measured. So what we ended up doing is we partnered with another health system. This is a BJC Healthcare, which is where the Washington University in St. Louis health system is kind of based. And we looked at the performance of this same model using kind of the sepsis-3 modern definition of sepsis, and looked at how well the model does in terms of its error under the curve, which is on the y-axis here. And what you can see here is that there are settings in which the error under the curve is 0.55. There are settings in which it's about 0.73. But this is still a lot worse than what was being reported by the vendor. And if you look at our hospital's performance based on the prior paper that had come out, our hospital at University of Michigan is actually that orange dot right here. So our observed performance was not some kind of outlier. It was really right in the middle if you look at, the kind of range of performance across this other health system. So not only is it a, reproducibility issue, the issues in trying to use this model at your hospital, there's also a transportability issue. Just because the vendor found that it worked doesn't mean that it's going to work at your hospital, but it might, because if you look at the upper range of this is much more similar to what the vendor is reporting than hospitals A and B down here, where it's a lot worse. Interestingly, this turned out to be in part related to a transparency issue, because one of the things that was actually not available on the original information sheet provided by the vendor was a key piece of information that the model was using to generate its prediction, which is whether a doctor had already ordered antibiotics. So antibiotics was not just one predictor in the model, it was at least 5 to 10 predictors, because every broad spectrum antibiotic was represented by its own predictor variable. That's something we actually didn't know when we published our paper. This came out kind of after the fact. So what was ultimately happening with this is this. Prior to a patient developing sepsis, the score really wasn't that good. It wasn't able to figure out who had sepsis. But the moment that sepsis was clinically recognized by a clinician and they would order antibiotics, that ordering of antibiotics would raise the sepsis score and cause the model to think that now this person has sepsis, at which point the model would alert the clinician that this patient has sepsis and that they should consider starting antibiotics. So there was this kind of circular logic that was there. And I would argue that had we known that this was actually a key predictor in the model, we might have just decided not to look at this model at all and potentially not even use it, or use it in a totally different way. So I think that, even though this ultimate result manifested in kind of issues with reproducibility and transportability, the real core issue here in my mind is actually one of transparency. So a couple other issues about models, and I'll move on to issues around implementation, and we'll try to wrap up a few minutes early so that there's time for discussion. So one issue is that we often, when we look at model performance, even retrospectively, when we look at sensitivity and specificity and kind of other things, we don't have a notion of how good a model needs to be for us to actually find it useful, or for the model to be worse than no model at all. And there's almost an implicit assumption, at least in the world of informatics, that if you are receiving information from a model, even if that model is not perfect, you'll end up arriving at a better decision than if you had no model available to you. But at least in the world of prediction modeling, that is not necessarily true. Now, ignoring the issues of trust, because you might see a bad prediction and decide not to use it, if you were to act on the predictions that you got, you can try to quantify what is the benefit conferred by identifying cases who you then intervene upon, and the harm conferred by identifying false positives, who are patients who you might intervene upon, who actually didn't need that intervention. Now, that harm may not be necessarily to patients, because if your intervention is a sepsis alert, you checking in on a patient may not cause them harm necessarily, unless you're automating the prescribing of antibiotics. Usually the harm there is felt by is to the clinician who's receiving a bunch of extra alerts that turn out to be false alerts. And similarly, the benefit the benefit may be to the clinician, it may be to the patient. But if you can try to quantify this, there is a way to look at what is the kind of cost benefit ratio, which is not a function of dollars or pounds or actual physical cost. It may just be a relative cost of how many patients are you willing to see for every one patient who's a true positive. You can actually calculate this measure called the net benefit. And if a net benefit is a negative number, when you calculate this, what that tells you is that if you were to act on the model's predictions, you would cause more harm than good. And so in my mind, this is a situation where the model is actually worse than no model and has nothing to do with the intervention, has entirely to do with the clinical context and the observed performance of the model. So just something that, I think we often underemphasize. This doesn't come up a lot in machine learning research, but there's a way to look at this. And the same model can actually be useful in one setting and not useful in another setting, because the scaling that we apply is a different scaling based on the decision that we're trying to make and the consequences of being wrong. The very last one, and that's a model-related issue, is this issue of predicting non-modifiable risk. So if we're trying to reduce readmissions, we might use an AI model to predict the risk of readmission. We might use an AI model to predict the chance that a readmission can be avoided with an intervention, which some people would say is something like an individualized treatment effect or a conditional average treatment effect. Now, oftentimes we can't even estimate that second one, so we often intervene based on the first one. But many of the interventions based on purely the risk of readmission have failed, largely because at the highest end of the readmission risk spectrum, most of that risk is being driven by chronic medical issues, which are not in and of themselves, directly modifiable. They might be slightly modifiable, but not modifiable to the degree that you can actually prevent readmissions. And so there's been a lot of recent shift in the literature towards people trying to estimate this conditional average treatment effect rather than trying to estimate purely the risk of an outcome like readmission. Okay, so I'll share a few examples, and I think we'll try to wrap up in about 10 minutes of why AI interventions fail. So imagine you have a perfect model. Why could a perfect model fail when you try to intervene based on that model's prediction? And here are some of the reasons, and I won't read them here. I'll just jump into the slides and show some examples. So I think the first thing to know is that just because you have a good model doesn't mean your intervention is going to help people. We tried to do this study where we predicted the risk of patients showing up in an emergency department in a 3-county area in the state of Michigan. And then we implemented a randomized controlled trial where at the highest spectrum of risk, patients got randomized to receiving a care coordination intervention or receiving usual care. And even though we had a model that was fairly accurate in its ability to identify who is at the highest risk of showing up to the ER, when we actually tried to wrap a randomized controlled trial around it, we didn't get any benefit. And that was largely because our intervention required us to call people. And when people receive a phone call from a number they don't recognize, what do? They don't pick up the phone. And so you can have the world's best model, but if your intervention is too simplistic, is something that is not readily acceptable to the people you're trying to deliver it to, you won't actually end up improving the clinical outcome that you're trying to improve. Another one is this issue of workload. So I won't go through what I'm showing here in detail, other than to say that each of these lines represents the proportion of patients generating a sepsis alert per day. And each line is a different hospital. And so we were curious about our sepsis model and trying to figure out what was the rate of alerting in the time leading up to COVID and in the kind of handful of weeks after the first case of COVID back in 2020. Mainly because when we had our initial surge of COVID, even though we had fewer patients in the hospital, we actually had a much higher rate of sepsis alerts happening, to the point that this yellow dotted line is where we actually turned off sepsis alerting. So that first dotted line is our first case of COVID. That orange dotted line is where we turned off for several months our sepsis alerts at the University of Michigan. And what we found here is that, it's very hard to measure workload. But in this case, our frontline nurses actually asked us if we could turn the alerts off because they were so bothersome. But we were able to show this is not a unique phenomenon to our hospital. This was something when we looked across 4 health systems encompassing 24 hospitals, that we saw some fairly consistent trends of sepsis alerting going much higher during the pandemic than just before the pandemic. And many of these other systems weren't necessarily using the sepsis model yet. They had it running in the background. But in our institution, because we had it piloting in a couple of units, we ended up actually turning it off. So workload, you can't measure it, but if you can measure it, it can really have a big impact on the way it feels to use a model. And that can be a function of the model getting worse or the model generating too much work to where it actually bogs down the frontline clinicians. I think readiness for change is probably one of the biggest ones. An example I'll give is a consideration in our hospital around using a falls model. So the current state in our hospital is that nurses screen all patients for their risk of having a fall while they're in the hospital. We have a standard set of criteria that we use to do that screening process. And ideally, we would like to use AI to prevent falls and reduce workload. But the challenge is that we asked our falls committee if we had a model that was accurate and could predict which patients would have a fall, are we willing to not screen low-risk patients and only screen the high-risk patients based on this model? Because for this model to actually be useful, it would ideally reduce some of the workload for the frontline nurses. But culturally, we are not ready for this change at our university hospital, because even if we had an accurate model, the falls committee said, well, falls is such an important topic that we would not consider shelving or not using the screening process on low-risk patients. And so if we're going to screen everyone anyway, we just didn't see much of a reason to add a model that could predict falls to this process unless there was something we were going to do differently for those patients. Resource constraints is another one that we often don't think about. You might, when you evaluate a model, find that a model has 90% sensitivity, 90% specificity, and that it performs really well. But let's say you were using your model to predict which patients go to the ICU. And what you said is that if someone's risk of going to the ICU is higher than 20%, we're going to preemptively just transfer them to the ICU to make sure that they see the benefits of that intervention, assuming that the intervention here is that ICU transfer. So in this second to last box from the right, you see the bunch of yeses and nos. These are the patients who, based on their predicted risk, would actually end up getting transferred to the ICU. So what you see is in that second to last column, there are 6 patients who would get transferred to the ICU and 4 patients who would not. And the assumption you make when you're evaluating your model is that your sensitivity is a good marker of how useful your model is if your sensitivity is going to be linked to being able to actually deliver the intervention to everyone who's positive. But if you only had 3 beds open in your ICU because you have a constrained ICU without enough beds, then those last 3 patients who turned out many of those actually needed the ICU based on retrospective data, only those 3 patients wouldn't actually see the benefit, because in your models, in your resource constraint of having 3 open ICU beds, only the first 3 on this very right would actually go to the ICU, and the other 3 just below that would not. So resource constraints can affect the apparent sensitivity or realized sensitivity of the model. So just because your model calculations showed 90% sensitivity doesn't mean that you can assume it's going to, all 90% of those that you identified will actually receive the intervention. And if only a small percentage of those that receive the intervention, then is your sensitivity really 90%? You could think of your realized sensitivity as the actual number of patients who actually were able to get the intervention. And I use ICU here as an example of showing a situation where we really have a fixed constraint, but you can imagine the same thing, being applied to things like medications, where in the United States, people can't receive a medication based on their health insurance coverage, or that there's a shortage. And so not everyone can receive a medication, even if they would stand to benefit from it. So how do we make AI better and safer? I'll skip around here just so that we have some more time for discussion. But I think one of the things that we're starting to see is a focus in the US and in the EU on regulating AI. And in the US now, for example, one thing that changed in the last couple of years is that the Food and Drug Administration now considers AI tools that warn of time-sensitive outcomes like sepsis, that those are now technically regulable as medical devices. I say technically, not actually, because there are still many sepsis models on the market that are not regulated, but technically they are regulable by the FDA. There's been attention given from the US White House to this issue. And in fact, one of the tenets of the recently released AI Bill of Rights that came out a year ago is that we should have safe and effective AI systems, and that you should be protected from unsafe and ineffective systems. And one of the examples of an unsafe or ineffective system that they highlight was actually this proprietary sepsis model that was being used so widely despite underperforming. And so as a result of that, even if it's not causing unsafe care, is ineffective. And so, causing people to do a lot of sepsis screens that are in the end not helping patients, but creating a lot of extra work and potentially contributing to burnout. In the case of the sepsis work that we did, the vendor actually ended up completely overhauling the model. And so the model that's now being rolled out starting this month is actually a very, very different model than it was there before. So I think that, even when the FDA or a federal government doesn't step in, there are situations where, peer-reviewed research can, I think, impact the trajectory of what's happening on the vendor side and lead them to kind of change what they're doing. There are certification programs both in the US and the UK. One of the certifications programs in the US is a certification program for electronic health records. And since many of the records now are coming bundled with algorithms, there is a push for including algorithmic transparency as part of the electronic health record certification program in the US. This is from a recently proposed rule that was open for public comments, where we had submitted a public comment, and we'll probably hear in the next few months about what is the decision around their kind of final update to this rule when it's finally published. So this is from the letter that we had submitted on algorithmic transparency, where we were really advocating that those model information sheets should be in the public domain, and some very, very basic information about models, like what predictors go into them, should also be in the public domain. There's work happening to kind of continually take some of the existing reporting guidelines and make them more relevant to the space of AI. And so I think the Decide AI guidelines were published in last year. There is the Tripod AI guidelines coming. Probast AI guidelines are in development. The Spirit AI guidelines and the Concert AI guidelines were already published. And so the START AI guidelines are also, I think, being submitted. And so there's a huge push towards making sure we've got reporting guidelines in place that capture specific things that are relevant to machine learning models that may or may not necessarily apply always to regression models. But because of this issue that models don't always transport across settings, we do have to make sure that we keep our own house in order. And so, one of the things we've been doing at the University of Michigan is we have an AI governance committee that was established in 2018 called the Clinical Intelligence Committee. And this is a screenshot of some of our model cards that we have, that if you click into these, captures some relevant information about what is the model, what is it trying to predict, who is the clinical owner at our university, and who's the developer or doing the evaluation process. And in some cases, it's our committee. In other cases, it's a research partner who's working with the clinical owner to do that evaluation. So this is just a screenshot from that. But I think there's, centralized governance is not going to fix everything. We're going to need local governance at individual institutions to make sure that even if a model works generally, that it actually works in the setting where we're trying to use it. I think getting clinicians to be more aware of not just the benefits, but also the issues in terms of using AI, so they don't oversimplify things that they see online and get overly excited about stuff that actually has major problems with it. We need basic kind of medical education. This is not something that I think we're going to get clinicians up to the level of experts, but if they can at least have some sense of reasoned skepticism, this will help them make sense of things that they see in the media and the literature and elsewhere when it comes to the space of AI. And so this is a curriculum that one of my colleagues is developing at the University of Michigan, Cornelius James, along with folks from our College of Engineering, our law school, and the medical school. And, I think this is something that we need to think about as kind of, just like evidence-based medicine is, taught in medical school as a key part of clinical reasoning. It's unfair to expect that clinicians will have any clue what to do with the space of AI, machine learning, or even prediction modeling if they have kind of no exposure to it in any kind of way during their training, either during med school or in their postgraduate training. I think partnerships also play a big role. And so a lot of times you shouldn't assume that you as a health center are alone. Many places are going through similar issues and trying to use AI. And so we participate in a number of partnerships. One of them that I highlight is the Health AI Partnership, of which we're one of the many members now, and one of the growing partnerships. So I'll stop there. I appreciate questions and discussion and look forward to it.
Awesome. What a fascinating talk and very, very thought-provoking. There are a bunch of questions appeared in the chat, which I will go ahead and read out, unless if you've asked a question.
I can read it, yeah.
So I'll read them out. I think it's sure. nice to tell the back and forth. So
Sure.
first question I think related to like the regulatory aspect was wondering what your thoughts are on how to increase incentives for reproducibility and transparency. So you touched on the kind of regulatory aspect, but I wonder if there are other ways that we can encourage kind of better practices in this context.
Yeah, no, I think that's a great question. And what I will say is when it comes to transparency, there are some things that are much harder than others. I sympathize with the issue that, sharing large healthcare data sets is hard, and we need better ways to engage people whose data are included so that they have ways to opt in and opt out of that data collection. I mean, I think in the UK, there's the UK Biobank. There are other places where there are, quite large data sets that have been assembled. But for whatever reason in the US, with healthcare data, it's very hard to do that. And I think groups like the National Institutes of Health are kind of including data sharing plans and setting new norms for what is expected when it comes to sharing data generated from publicly funded research. But I think transparency around data is actually quite challenging. Transparency around models, I think, is a slippery slope because of intellectual property, people often don't want to share model objects, which makes a lot of sense. And I respect and I understand. But oftentimes, they take that lack of transparency around model objects way upstream so that you don't even know what the predictors are going into the model, or if as an end user, you can't talk about it publicly, which to me is essentially saying this is no longer patient-centered. If I can't tell my patient what is being used to guide a decision that I'm going to make, not even just the, like the issues around explainability, I just mean what factors are being considered. If I can't even have that basic of a discussion, then I think that's kind of a model we probably shouldn't use. So a lot of my focus has been, forget the more advanced mathematical explainability, like SHAP, Lime, partial dependence plots. Those things are great. They have a role. But for patients, they often want to know, are you considering X, Y, or Z factor? What are you considering, right? If you get a credit rating, you want to know what goes into your credit rating. You don't really necessarily need to know the exact formula, but you want to know what you can change. And I think that same thing is there. So what are the incentives? I really think if companies did this, there's so much positive public relations to be had that I almost don't see why companies don't at least start at that level of transparency. I've made this argument to colleagues at Epic and said, I think there'd be so much positive reaction to this. I just don't see why you wouldn't do it. And if there was backlash, that's actually good because you'll get the backlash early and you won't get it after it's adopted by hundreds of health systems, and then you can fix it. So, I have just a different view on it than I think a lot of the US healthcare vendors.
That's a super interesting point. There seems to be like a reputational risk, right, to these stories coming out, like after the fact rather
Yeah.
than companies kind of addressing it head on. Paula, you had a question in the chat and your hand is up. So would you like to read out your question, or perhaps you have a different one?
Hi, good job on pronouncing my name correctly. So I had a question regarding the clinical trials bit that you mentioned, and you talked about how you tried to implement a clinical trial to kind of evaluate your algorithm, and mentioned that the intervention that you had planned, or the kind of the evaluation didn't go as planned because of patients not fully kind of responding to your plan. And my understanding in terms of clinical trials for medication is that patients sort of, you recruit patients, they kind of sign up, so they have an understanding of what to expect during the clinical trial, and then you kind of randomize them. It sounded like in this case that was sort of done at the level above, like you randomize the patients and then kind of call them, which is maybe why they didn't respond. But I was wondering if you had any more thoughts on whether it is possible at all to kind of go about implementing those AI algorithms in a way that we introduce new medication to the market, and kind of talking about the interpretability or limitations, or kind of what the doctors are dealing with, like we talk about side effects with medications, for example, or yeah, that's just random thoughts.
Yeah, so I think the deck was stacked against us for that particular use case, because what we were trying to do is keep people out of the ER, and there's a number of medical and social reasons that keep people going to the ER for a variety of reasons. We actually did a lot of stuff behind the scenes to try to make this work. So for the most part, we tried to make sure that the phone call came from a social service agency they were already familiar with, that they were already getting care from. So we actually had 12 different social service agencies participating in the effector arm of our trial. And the issue we were saying was, it's not so much that these patients don't have access to the agencies, it's that they're seeing so many different agencies that no one agency is their kind of primary agency. And so what we did was, in this process, we assigned one to be primary and to be kind of almost like your primary care physician, but on the social services side. So I think there has been other very, very widely publicized trials in predictive hotspotting that have also failed. So I think that's probably a situation where it's just a very difficult to intervene on population. And so I think we could have designed the trial a number of different ways, but I'm not, I think every other trial has failed. So if ours had succeeded, I think I'd have a lot more scrutiny about why did it succeed than if it failed, because other ones have also failed. And there might have been a second part to your question. I think there is some comparison to, how drugs get validated in terms of how algorithms, but I also think it's a bit of an oversimplification. And if we really apply that standard to all algorithms, I think it'll actually be harmful, because if you think of the different ways, when I search for an order to prescribe, there's a little bit of AI that checks what is the common order sets that are, pulled up in that clinical context. And almost like Google, I see a list of order sets that are pre-sorted using some kind of AI. I mean, is that going to be subject to a clinical trial? Probably not. So I think the issue is there's so many ways that we administratively use AI to improve clinical operations that don't necessarily affect the patient in a direct way. They may indirectly affect access to care, other things that I think we don't necessarily want to hold all algorithms subject to the same rules that we think when we apply to drugs. And a lot of it will probably come down to the issue of what harm could we cause. And if it's high risk, then we probably do want to be more careful and apply that same standard.
That makes sense. Thank you.
Awesome. I think I'm going to try and get to two more questions. I'm going to read out Awaz's question from the chat, which is, I guess, around the transportability question. Well, yeah, which is what should be the ideal way in which one takes a model such as the epic sepsis model one and adapt it to the changing circumstances or in different contexts. This is a very high cost, and doing this properly may just be too much of a hassle for admin or clinical staff.
Yeah, so I think I'll talk about the specific example you had here, and I'll talk about what we could have done differently versus what we actually did. I would argue that the model wasn't bad. I mean, these are patients coming in with tachycardia, fever, high heart, low blood pressure, looking in many ways just the way patients look like when they have bacterial sepsis. So one could argue the algorithm wasn't necessarily wrong in identifying all these patients as having sepsis, and therefore the rate of our sepsis alerting to go way up. What was wrong is that the intervention we had linked to that model was one in which it was recommending you do all the things for bacterial sepsis, which were not relevant to this population. And so the way we dealt with this was to shut off the alerts, period, mainly not because we felt like the algorithm wasn't identifying patients who were otherwise ill, but rather that the intervention that was being alerted and pushed to them was one that was just not relevant to patients with COVID. Early on, we were giving people broad spectrum antibiotics because there was really nothing else you could do. And you had to assume that these patients with horrible x-rays may be super infected with some kind of bacterial infection on top of COVID. So I think, again, what could we have done? I mean, another thing we could have done is we could have changed the threshold and moved the threshold higher so that fewer patients alert, but the ones that alert, the model is even more sure that they have sepsis. And maybe those are the patients who had more of an indication for bacterial sepsis. But to your point, it's really hard to do this when there's a moving target. And last week of February, the first week of March, and the second week of March felt extremely different at our hospital in terms of what was happening and all the moving pieces that were there. So I don't think you have to, apply the most rigorous of statistical standards, but I think you do need to apply common sense. And I think in this case, the common sense was the model may be fine, but the intervention is not relevant, so we shouldn't use it.
Awesome, thank you. And our final question, I will ask Sedalia, hopefully I haven't butchered your name, to unmute and ask.
Hi, thank you so much, Karandeep. This is fantastic. This is the first time after my dissertation at the London School of Hygiene and Tropical Medicine that I heard from this. So I did a dissertation exactly evaluating the model using ProBAST. So I understand the challenges and I really resonate with a lot of things that you talked. I think one of the takeaways that I wanted to say is that I don't know what you feel about this, but I think there's a lack of incentive to evaluate the models. There's a lot of incentives to build models, but not to evaluate models. And I also think from a clinical perspective, I'm IC nurse by background, is that I think beyond the clinical awareness, what clinicians have to understand is that decision-making shouldn't be kind of changed just by having a model. I think it's very important for clinicians to understand that there's pitfalls in the models and that the decision-making tool should never be replaced by a model. And I do agree with you with all these alarms. In ICU, we can get more than 50 alarms a day, 60 alarms a day, different types of alarms, high alarms, low alarms. So I think instead of turning it off, maybe find a way that you can highlight without actually being an alarm, but finding common ways to do those. And the last question for you, Karandeep, is very much about the net benefit. So how do you envision that we could evaluate and, healthcare systems like the NHS and many other healthcare systems evaluate these models and kind of understand the cost benefit or do a cost benefit analysis on this? Because currently those things are not being done. And then it's very difficult to really understand exactly if you're having a benefit or not.
Yeah, I'll address two of those points. I think one is the incentives around evaluating models. I think it's definitely true that there are less incentives to evaluate than there are to build. And or more specifically, oftentimes the people who are incentivized to evaluate are the ones who built that model. And so it's then a little bit hard to take at face value the evaluation that you see published because it's coming from the group that also built the model. I think it's true in academia because many people kind of had given me the advice that why are you spending your time evaluating models? That's not where the excitement is. It's not where the grant funding is. None of my evaluation papers are funded by NIH grants. And yet they're things that I felt like were some of the more important things that I've done. But the other thing is that sometimes the other flip side is that the folks evaluating the models are the kind of model skeptics. And so then what happens is you see these really harsh evaluations. I think, ProBAST is potentially one of those situations where the people applying ProBAST are usually methodologically very rigorous. And so, they're going to say that for a variety of reasons, that are up to some level of judgment, you can say this model has a high risk of bias. But it's really the evaluations from the health systems who want to use something that where they're willing to think creatively and say, well, what if we move the threshold? What if we did this? Is there some way this could be useful to us? Those are the evaluations I'd love to see more of, because I think those are the ones that are happening in earnest. The people who actually are going to use it, they're not just the folks who don't have access or the folks who built the model, but they're kind of somewhere in between. So I think that definitely is there. The second point you touched on was net benefit. So just to be clear, the cost benefit here is not a financial cost and benefit. But what it does require is you to understand the trade-off. And the specific trade-off question is, how many false positives are you willing to tolerate for every true positive? That's the exact trade-off question. And there's a lot of decision theory where, you know, there's ways to ask that question using something called the standard gamble. And so there are papers out there where people have done it. So it's doable, but there's going to be a range. No two clinicians or no two patients will come up with the same value. But in breast cancer, they've done this. They've asked people, you know, how many unnecessary biopsies would you be willing to undergo for every one breast cancer that gets missed? And I want to say the number is somewhere around 20 to 30. And there's a paper on that. I have to dig it up and see. But on average, you can quantify some of that. And then the issue is, well, what is that? If your model can't achieve the level of performance where it can achieve that stated goal, then that model is actually causing more harm than good. And so, but first you have to quantify what is that trade-off, because if you don't have that trade-off in mind, you can't you can't really proceed. And in my mind, it's a little bit like Anscombe's quartet in that the same model with the same predictions in 4 clinical settings could be totally useless and totally useful. The threshold that you need to go take someone to surgery is very different than the threshold you need to prescribe someone a multivitamin. They're 2 totally different things. And so the same model could be useful for one, but not useful for the other.
Awesome. Thank you so much, Karandeep, for that presentation and for that great discussion. And thank you for everyone for attending. Our next activity as the Statistical Methods theme is a symposium on the 8th of November. I've posted links in the chat, but you can also find them on the Data Science for Health Equity website. So that is it for today. Thank you again to Karandeep, and hopefully see you all soon for a future event. Bye.
Thanks.